help me understand. You mentioned that you were trained manipulatively, or you were manipulative
Yep.
trained. That
Yep.
you were using Mulligan techniques and the
Yep.
McKinsey approach, but
Yep.
you felt like you were running blind.
Yep. I
Why?
was.
Why? You had all
Because
those
I was
tools.
treating I was treating symptoms
Yeah.
which gave short-term pain relief, but the people were coming back with the same symptoms.
Mm.
So I wasn't addressing the underlying basis of the disorder. And if you look at it, look, we see people who might be present acutely, and we know the natural history for 70% of them, they're going to get better. Doesn't matter what we do, they will get better. What we do know is that 30% of these people won't get better.
Mm-hmm.
Doesn't matter what you do to them, they don't get better. And I was seeing quite a few of them coming in, coming back, coming in, coming back. And I'm like, there's something missing here. I can modulate their pain for a short period of time, but they're coming back with the same symptoms again. They're telling me that the thing that I'm doing either is not working or it's only lasting for a short period of time, but their lives are significantly disrupted. They were distressed. And the tools that I had in my toolkit couldn't address that. That deeply unsettled me.
Mm-hmm. Peter, I'm thinking of those listening that are trained in the McKinsey Institute, and that third and fourth stage is recovery of function and prevention of future recurrence. And so they might say, well, Peter, you weren't doing a good job of teaching prophylactics.
Well, maybe that's right. But if you look at the evidence base for McKinsey, it doesn't look like it holds a lot better than other stuff that's out there. The effect sizes, and I suppose you've got to look at different groups as well.
Sure,
but if you look at the effect sizes for managing chronic back pain, for example, the effects are really small. They're not great. If you look at the trajectories of these people who are predicted not to do well, the things that predict them aren't about direction of movement or directional bias. There are much more things around fear avoidance behaviors, distress, people's protective behaviors. Those are the things that are more predictive. And we're not, I think those historical models don't really address that. They might be able to address that in terms of restoring someone's function. But I think we've embedded a whole bunch of biomechanical and structural belief systems in our models that aren't actually evidence-based, and we have to move beyond them. So that's not to say that, restoring function is really important, but maybe we shouldn't embed it with some of these, beliefs and that we really know aren't evidence-based. And I look, to be honest with you, I'm aware of a shift within the McKinsey system away from some of those rigid, pathoanatomical perspectives. But, words like derangement, I don't think are helpful to anybody. Like, what does that word mean to a physical therapist, or what does it mean to a person with pain? I don't think it's a helpful label.
Could inflammation also be just as detrimental to a patient?
Inflammation?
Yes.
Yeah, of course. So I think there's growing evidence around the role of inflammatory processes that can be centrally driven, lifestyle driven, mechanically driven, that can maintain pain states. There's quite a lot of evidence for that.
Yeah, didn't mean to interrupt you. I bring up that word because sometimes we may be comfortable with using the word inflammatory or inflammation about the patient's condition, but maybe
that's more evidence-based.
Is it?
Yeah. So if you think of something like modic changes, which is inflammation around the end plate of the disc, and that's a sign of bone edema, which is like an inflammatory process. So we know that those findings around a degenerative disc are more strongly associated with pain and disability than just a degenerate disc, for example. So that is evidence. It's like bone edema around an OA knee is more associated with pain than just an OA knee. Sure. So that is a sign of inflammation around the structure. But that inflammation could be influenced by lots of things like abdominal obesity, lack of sleep, significant chronic stress in a person's life, biomechanical loading. A whole lot of factors can drive those inflammatory processes. And often they're not a single factor. So I think we need to, one, understand mechanism and then look towards a broader understanding of what might be driving those mechanisms.
Yeah, I think we agree on that. So should we throw out all pathoanatomical use of an education to patients? Yeah.
No, of course not. So, we have to think, if as trained health practitioners, we have to go through a triage process. And we know that there are some things that on scan are highly relevant. So, for example, you might have someone with a central or posterolateral disc prolapse with raging radiculopathy. You might have someone with spinal stenosis with, bilateral leg pain, or central stenosis with bilateral leg pain that's provoked with extension and relieved with flexion. They're clear diagnostic categories. You might have someone with a stress fracture or an acute fracture with pain is highly relevant in those cases. And our studies have shown that there is a strong correlation with back pain and those pathanatomical findings. We know, for example, in modic changes, that's the same. But then you've got a gray box where you've got, other stuff that might show up in a scan, like a disc degeneration, facet joint arthrosis, disc bulges, annular fissures. Those things don't correlate so well. They don't predict levels of pain. They don't predict levels of disability. Those are not useful diagnostic labels, but we give them to people. I think that's where the trap is, because the likes of MRI scanning is very sensitive, but not very specific. So as a clinician, we've got to wade through, look at the person's presentation, assess them, listen to their story, take their history, look at their pain behavior, consider red flags, look at their scans, and look to see whether the findings on the scan are relevant for their clinical situation. And what we know is that, if you look at the evidence, the people we can categorize in terms of a clear pathanatomical diagnosis is probably somewhere within the range of 10 to 15%. But the majority of these people sit in this other box. They might have mechanical back pain or axial back pain or pain around the pelvis, sacroiliac joint pain. We can identify they have a painful structure, but what you see in a scan doesn't correlate with that. And this has been shown in a number of studies looking at the severity of a person's pain, disability, and this severity of their MRI finding. They don't correlate. Other studies have looked at whether what you see in an MRI scan predicts someone's future pain and disability. They don't correlate. So we can't be using those diagnostic labels to tell people that's the cause of their pain, because there's no evidence to support it.
Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.